So the next speaker is Renato Ambrosio, who will be speaking on applied artificial intelligence to characterize the risk of corneal ectasia among refractive surgery candidates. New member, whose paper will be discussed by Steve Wilson.
Good afternoon, ladies and gentlemen. Thank you so much. It's an honor to participate in this great meeting. My name is Renato Ambrosio from Rio de Janeiro, Brazil. This is my financial disclosure, including Alcon, Zeiss, and Oculus, and I'm also CEO of BRAIN, which stands for Brazilian Artificial Intelligence Network in Medicine. Interestingly, the first work on AI in ophthalmology, maybe in medicine, one of the first ones was led by Stephen Kleiss and his group on neural networks to classify corneal topography. I was fortunate to train with Steve Wilson in Seattle, Washington. He was the chair there. And Wilson was a fellow of Kleiss about 10 years before then. One of the papers published in 2003 with over 250 citations, we looked at topography and pachymetry to screen cases that were candidates, that were not good candidates for laser vision correction. We have patients like 2015, this is correct vision and normal slit lamp, that topography was keen to detect abnormalities. Ectasia is very important, isn't interestingly rare, and a decrease in incidence doesn't make it less important. We have a 25 years plus of conundrum, and of course prevention is the best strategy, and we need to understand the epistemology of ectasia, understanding what we know. The first reports were from 1998 from Theo Seiler, and he published 3 cases on LASIK for high myopia, and then a case that had form fruits keratoconus, and he defined form fruits keratoconus based on the surface topography with inferior stiffening. Those 2 cases allude to the pathophysiology of McGee with the 2-hit hypothesis. The biomechanical decompensation occurs in relation to the corneal resistance, the biomechanical properties, and the impact from the environment. Any cornea may undergo the decompensation in the cycle described by B.J. Dukes and Cynthia Roberts, and interestingly, eye rubbing is the major cause. So if you want to avoid ectasia, tell patients not to rub the eye. My good friend Damian Gatinel has a conjecture that eye rubbing is sine qua non for keratoconus. Eye rubbing does aggravate keratoconus and may even cause ectasia. It's not the same thing. And I agree with my friend Damian Gatinel, even though medicine c'est comme l'amour, n'est jamais ni toujours. It's sine qua non for corneal ectasia. Primary keratoconus doesn't require eye rubbing. It's definitely aggravated by it. About 12 years ago, I was keen to do this editorial with Bradley Rammelman, and the idea was to go beyond not over-detecting keratoconus, mild keratoconus, subclinical keratoconus, fruits keratoconus with placido-disc topography. We were interested in looking at susceptibility for ectasia using an enhanced screening, and this is a very important case. This case was for 2008, had a thin flap LASIK with a subbulbar keratomylosis, with a proper residual stable bed over 300, PTA less than 0.4, and a relatively normal topography. The retrospective evaluation of the pentacam with the Bell and Ambrosio, we identify a bed D that was higher than 1.5 and arcmax lower than 400. Interestingly, the topography and some analysis would say this is pathognomonical for form fruits keratoconus. So we did a study that looked at the variability of subjective classifications. We sent to 11 experts, 25 cases. This was case number 6, and the mode was 0 with 2 scales, the 1.5 Steve Kleiss scale and the half a diopter normative Holiday scale. Interestingly, the variability, we need objective data, and the IS value in a population that has comprised of 3,278 pre-op LASIK data from stable cases and 105 cases that we had from pre-op ectasia, we had the IS value with less than 25% sensitivity. It's very specific though. The band D, which was not available at that time, this is truly a black box thinking idea. We go back and we see what happens with the data that we have available. We can do better with the pentacam random forest, which is AI applied to the tomography data that we have. But we have to go beyond, and the idea of doing biomechanics with a Corvus ST, which is a non-contact tonometer that takes in 31 milliseconds, 140 frames, and characterize corneal deformation so that we can see if the cornea is softer or stiffer. And we have SPA1, Cynthia Roberts parameter, and the CDI that was led to the Trotman Award in 2017 by a colleague, Ricardo Guerra. The integration of tomography biomechanics came as also AI. The random forest with even-out cross-validation was able to detect in a virtually perfect separation for the clinical ectatic cases. With a threshold optimization, we get 90.4% sensitivity. Interestingly, we get this in normal topography eyes from patients with very asymmetric ectasia cases. This is a very important model for us to detect pre- or sub-topographic abnormalities. These two reports, the CBI and the TBI, are the first and second most cited papers in the Journal of Refractive Surgery. We're honored to see that. And also the SPA1 paper from Cynthia Roberts is the number 5. That's the importance of this work in ophthalmology and refractive surgery. The TBI optimization was important because some normal topography eyes came with a normal TBI V1. So we did a larger study with more data, increasing from 94 to 551 normal topography eyes, and increasing also the normal and keratoconic eyes. So these patients will lead to more optimization of the AI. This was my AOS thesis published in 2023 with an increase in 10% on the sensitivity for the very asymmetric ectasia cases in normal topography. We kept and even improved a little bit for the clinical ectasia cases. The second part of the story is the impact from surgery. The relational tissue alter based on the pre-op data of the stable versus the ectatic cases. We included age, thinnest point data, flap, and ablation, and this relational tissue alter outperformed the PTA and the residual stromal bed. So the brain-enhanced ectasia software, the BEAS, combines tomography data, biomechanical data, and also the impact from surgery. I just got some wisdom from Socrates. All I know is that I don't know everything. I know that I have learned a lot, and this is a beautiful evolution of knowledge, but we have to go beyond not over topography and tomography to multimodal diagnostics. Epithelial thickness, genetics, and molecular biology will definitely give us information about ectasia susceptibility. Characterization of ectasia susceptibility should be combined with the objective data from the impact of surgery. And of course, Vijay Dup's work, finite element models, can improve that as well. AI will play a major important role. Thank you very much.
And Steve Wilson will discuss the paper.
I want to thank the organizers for inviting me. As I move towards my retirement in December, closing my lab and ending my clinical practice, one of the great pleasures is seeing your fellows who you've had over the years become such great ophthalmologists and scientists, and Renato's among the best I've ever had. 15 Brazilians I've had for fellows. Irene, I have no financial interest in topography, tomography, or any of those things. Renato and his colleagues have made really impressive advances since he completed his fellowship with me, and their work on exploring use of AI is just a continuum of that. As Renato mentioned, the first application of AI to corneal mapping and screening patients was actually Steve Kleiss and his colleagues way back in 1995. And as these AI algorithms continue to improve, I think this is one area where AI is going to have some important application. I'm not a huge fan of AI. I don't believe that it's going to replace all the scientists in this room. So we'll see if I'm wrong over the years. But I do think it has a usefulness, and this type of information is one of them. The accuracy of the posterior corneal curvature measurements remains one of the areas of dispute between leaders in this field, and I think it hasn't been answered yet. It's not clear to me in this algorithm how much the posterior curvature really has a contribution. Maybe you could mention that. But definitely the Scheimpflug imaging devices have gotten better, but there remains this issue of the placido-based devices having more accuracy, especially when it comes to the posterior curvature, which they're one of them. in my opinion, are accurate. So that remains a problem. It's too long to talk about that, but Randleman had a paper in AJO here recently that has more information about that if you're interested. But I think this is going to be a growing area to help, especially people in practice that maybe aren't experts on corneal topography or tomography. And we have some of those in our own practice at the Cleveland Clinic. And I think they're looking forward to having things like this that help them decide if a patient's really a good candidate or not for refractive surgery. Thank you.
Thank you, Dr. Wilson. If I may have the last slide of my talk. So AI, what is AI? AI is when we work with machines. We program them to do what humans can do. I would just say we program machines to do what humans can do better. This is important because designing devices that have human capacity is one part of the story, but I would just cross human. Not to replace, but to empower us, to see what we can't see. We can analyze 3, 4, 5, 10 parameters if you are very good. But the machine can analyze thousands of parameters in seconds. And that is beyond our human capacity. So we apply AI. We apply AI. Now, AI is all about algorithms. Algorithm of A2I squared, which is applied artificial intelligence, and ancient intelligence, which is the whys and the hows. And I will even go beyond with some artificial intuition. And the AI gurus, they would say it doesn't exist, but I would say eventually we'll understand how it works. In the RSA Fellowship and Network, we have a very nice journal club. And I discussed this paper with many colleagues, brilliant colleagues, and the black box thinking came in 2 different folds. There is a fear of a black box. You have a black box that tells you what to do and you don't know how it's going to have a response. But the second black box is the good one, is the understanding what happened and scrutinizing the data so that you can prevent complications. And interestingly, we have a study that look at normal people that work at the hospital that I teach, and we have Stephen Kleist classification of topography with 5.77% of abnormalities on topography. But if you go to abnormality on tomography, it goes to 10% objectively. And TBI, different thresholds will go 32% in a lower threshold. So this is not keratoconus. This is ectasia susceptibility. And of course, we need to correlate that with longitudinal studies. We need to correlate that with genetics, and all that will play a major role. So keratoconus diagnosis is not the same as ectasia susceptibility. And all this work is going to be the future for more data with epithelial thickness, molecular biology, and genetics. So I'll leave time for more discussion. Thank you so much for the honor. I'm really grateful for being here.
Yes, questions? Rosha, Medical University of South Carolina. Renato, congratulations. This is great, and we know all your work for all these years. And I think this is one important area that AI can really help us, not only for the diagnosis of corneal ectasia keratoconus, but detecting progression, right, in clinic. There's a huge variability. I was just talking to Peter Hirsch earlier today, right, with all the devices that we use. So we're using OCT to look anterior posterior cornea and that relationship, or shine fluid tomography, or combined shine fluid plus CETO. And I think, again, having that database that we can gather really just to help us, using that tool even to detect progression and outcomes for treatments, cross-linking, CTEC, INTEX. Just want to hear your thoughts.
Thank you, Carol. Thank you so much for your words. Interestingly, diagnosis is different than diagnostics. Diagnostics include screening, confirming the diagnosis, getting the severity and classifying the disease so that you can get prognostic information. And the prognostic information will be important for you to say, you need to come back in 3 months, you need to do cross-linking now, and of course you have follow-up. And the threshold to detect what is a difference from the baseline exam that is significant for say you are progressing is very important. So all this data will be important for customized or personalized medicine. And this is going to be important for refractive surgery, for therapeutic surgery, keratoconus, refractive cataract surgery, which differs from standard cataract surgery based on the planning. And planning with AI, with all this data, that will play a major role. Cataract surgery doesn't think about keratoconus, but if you think about keratoconus, the relevance is the quality of vision, the impact on the laser, the formula, and if you need a laser vision correction after that, that will play a major role. And all this will be integrated with more relevance as time comes.
Yeah, Dr. Roger, Michael Singer says, a retina specialist, as I sit here, obviously, this is far from my skill set, but as I'm looking and having dealt with this on a personal level, where does dry eye play in all these measurements? Because I know that, you know, when we look at people, if we test them for EDT or visual acuity, if we want to do OCTs, dry eye plays a big factor, actually. I mean, I put a lot of pumped up plugs as a retina specialist, and my people are happier with that than my 23rd aflibercept shot. So the question is, in your models, has dryness changed with your outcomes for artificial intelligence?
I see Marguerite McDonald here, and I remember the work that she has done with Keratograph 5M, for example, which is a machine that is a topography, plays a placido-disc topography with some imaging devices that is built with the topography. So this will be important for tear breakup time, megamography, and some other data that we can even improve with, and AI will definitely help us there as well. With tomography, the sensitivity of tomography is definitely less than the placebo for the very fine detail, but it's good enough. And it's better than placebo because it's less sensitive to dry eye. So the long answer to the question can go with more studies, but the short one is we looked at dry eye tomography data with shine fruit. It doesn't affect so much by the dry eye. It's definitely affected, but it's not so much. But it's something we have to take into consideration.
Great. Thank you so much. Our final speaker of today will be Dr. Carolyn Rocha, whose topic is visual performance and objective depth of focus from ray tracing aberrometry in small aperture optics intraocular lenses in eyes with aberrated corneas. And her discussant is Dr. Peter Kirsch.
Thank you so much. It's a pleasure being here.